afternoon and welcome to our webinar series. We're so happy to resume our webinar series, and we are particularly happy to restart it with such an exciting topic: the challenges and opportunities of centralization and decentralization. And the subtitle reads, Informing Structural Reform of the Swedish Health System. So it's about the current state of the Swedish health system. And we have in the show notes a link to the recent hit of the Swedish health system, the monitoring tool describing and analyzing the Swedish health system. It's just came out today, actually. And we will see what the current issues around the Swedish health system are with regards to centralization and decentralization. And we will learn from other countries, in particular from Denmark and Finland, how to deal with these issues. And these are really very important questions, because what services and what tasks should be on what level? Big discussion. How do we establish accountability with the government if we hand down some of these services and tasks to the regional or to the local level? How do we ensure being receptive to local circumstances and patient if we centralize some of the services and tasks? And actually, what is a good setup of a country? What is a good balance between centralization and decentralization with regards to all the big challenges to come, strengthening the health systems, strengthening the resilience of health systems, strengthening the performance, regulating future technologies, digitalization, and all these issues. And I think today we will get a couple of responses, a couple of good clues what should be actually done. And I'm so happy to announce a fantastic panel of speakers. Today, our keynote speaker is Anders Arnell from Lund University, and he will fill us in on the Swedish situation. What is the pros and the cons of the current setup of the Swedish system and why it might need to reform a little bit? Then we have from Sweden also Jean-Luc Afghayastan. He's from the Swedish Agency for Health and Care Analysis, and we are very happy to have him around because he's meant to set up a commission which is laying out plans for decentralization, recentralization reform. We have also Professor Carsten Frankenbeck from the University of Copenhagen, Denmark. He will fill us in on the reforms in Denmark. And I'm very pleased to say that with us is also Lina Kaiser Tynkinen from the Finnish Institute for Health and Welfare in Finland, which just underwent a very important reform of recentralization. And last but not least, our close partner Ingrid Schmidt from the National Board of Health and Welfare in Sweden. She will fill us in a little bit on the culture of policymaking in Sweden. Okay, that's the background, and now just two things on the housekeeping. Please use the chat for your comments, for your questions. We have a panel session at the end, and we'll feedback your comments to the panels. We will record this session and put it lightly edited on YouTube in a couple of days. So that's about it. I think we can actually start. And please, Anders, the floor is all yours. Tell us about the Swedish situation.
Thank you, Matthias, and hello, everyone. And of course, Sweden has the answers to all of those questions that you mentioned, Matthias. No, we don't, but we have experiences, and I will tell you a bit about them. I have 3 slides. And the last slide is focusing the theme of this webinar. The first 2 is about putting the issue of structural reform in Swedish healthcare into context. To put Swedish healthcare in an international perspective, I mean, a lot of things looks good, and it has looked good for a long time. Well equipped with the resources, both financially and when it comes to human resources. You can read more about this in chapters 3 and 4 in the new HIT. Also, very good medical and health outcomes. Just about every measure, if you look at the situation today and also the historical development and compare with other countries, Swedish healthcare usually come out favorably. You can read further about this in sections 7.4 and 7 through 7.6 in the new HIT. So you might wonder, okay, if not broken, why fix it? I think that this cue from Jeremy Hunt in the UK Parliament gives a clue about the darker side, if you will, of Swedish healthcare. Of course, we are not at all satisfied with a lot of things. First of all, we've seen persistent access problems, problems with waiting times, not only after COVID, although it's developed to the worse since COVID, as in many other countries, but also before that, persistent problems with the access. Also, poor continuity. The standard organization in many other countries that you have your own personal doctor in primary care. That has not been the standard in Swedish healthcare. Also, a lot of structural problems. I mean, overall, there is no shortage of doctors and nurses, but if you look at things more specifically, we have since long have a shortage of GPs. And also, and perhaps more recently, a shortage of hospital nurses. Nurses may be around, but it's difficult for hospitals to recruit and retain hospital nurses, leading to a shortage of hospital beds. Swedish healthcare have the lowest number of hospital beds now in European Union. And this is more than linked to experience of a poor working environment. Also, I suspect this has been the case also since long, but with increased transparency, follow-up and so forth, it is getting more apparent that we have both geographical and socioeconomic inequities. That doesn't go along well with the Swedish Healthcare Act. And besides this, we of course have all the problems that are there in other countries with demography, leading to problems with long-term financing, staff shortages. We also have continuing medical and technical developments, including e-health solution. And the debate is that it's perhaps not possible to meet all of these challenges and solve the existing problems with the governance that we have today in Swedish healthcare. Now, coming to the theme of this webinar, decentralization, centralization, if you look at the historical development in Swedish healthcare, I think you can say that a decentralized system was seen as the solution more or less in the past, but not today, at least not at all to the same extent. Throughout the 60s, 70s, 80s, there was a transfer of responsibilities from national to regional government, decentralization within regions, and this is also. I mean, the argument was that it's good if you can have integrated care, and if we have the regions in the center of power. In the 1980s, we didn't see any transfer from national level to the local level, but we did see some transfer of responsibility of long-term care for elderly from the regions to the municipalities. So another form of structural reform. And during this decade also emerging centralization tendencies, national government becoming more interested in earmarked grants, as an example. And then if you look at more recent developments, in particular the last 10 years, we have seen a number of initiatives pointing in the direction of continuing centralization trends. We have a new Patient Act focusing healthcare guarantee. We have more earmarked grants, which regions tend not to like. Well, they like the grant, but not the earmark part of it. We also seen more agreements between national government and the Association of Local Government, SALAR. That is one way for the national government to try and influence developments in health care. Interestingly, we have also seen more collaboration on a voluntary basis between the 21 regions. For example, and this has been supported by the national government also, for example, when it comes to regional cancer centers, concentration of specialist care in general, and also a national system of knowledge management. And to sum things up, this has led to a current situation where we have quite complex and detailed national governance in health care, but problems remain. A number of studies have, for example, concluded that the Patient Act has not been implemented so far. A number of studies have suggested that earmark grants is perhaps not the best way to try to influence developments. So overall, problems remain, and this has also led to the initiation of a new parliamentary commission or investigation starting up initiated in June this year, and it's now starting up its work. But Jean-Luc can tell you more about that. So I'll stop sharing from here. Thank you.
Anders, thank you so much for this excellent overview. That was really concise, at the same time very informative. And there are a couple of very important messages coming from it. First of all, you said, oh, maybe we need to change the governance to resolve some of the problems we are now facing. And clearly, centralizing, decentralizing is part of changing the governance and making Sweden, kind of empowering Sweden to get some of these issues really resolved. And the second thing is, I mean, there's a constant move since the 1960s of decentralization, then a little bit of recentralization, decentralization again. So it's a constant effort to find some sort of a balance. And I assume, you know, this follows specific problems and issues, and there's never the perfect balance, but it's an iterative process, isn't it, Anas?
It is, definitely.
Very good. Thank you so much. And now I'm very curious to hear from Jean-Luc about the next steps. We heard the problem analysis from Anders, and apparently the government is very keen to do something about it. And what the government is doing is, let's have a committee and let's ask the committee to produce some sort of suggestions. So please, the floor is all yours, Jean-Luc.
Thank you very much, Matthias, and thank you very much for the invitation. And also, once again, thank you, Anders, for the great overview of the Swedish healthcare system. As you mentioned, Matthias, the government in Sweden is trying to find the right balance between centralization and decentralization. So the government has formed a parliamentary committee looking on structural reform of healthcare. It was decided to start this committee this summer in June. So the work has just recently begun. Lucy, I can have the next slide, please. From the Swedish government's perspective, they point out several problems. I think Anders has highlighted several of these concerning shortcomings in some areas and regional differences in healthcare, which is a problem regarding inequality. The government also feels that in some respects, the efficiency of the Swedish healthcare system could be improved. So the efficiency of the Swedish healthcare system, and the government also thinks that its ability to control and coordinate health and medical care in Sweden is limited with the current setup. And the government also points out that lessons learned from, among other things, the corona pandemic, speak in favor of a strengthened government, responsibility and governance. Next slide, please. So therefore, this summer, the government decided to form a parliamentary committee which will be tasked to produce a decision support to enable a gradual and long-term introduction of transfer of governance responsibilities to the national level, finding right balance, as Matthias mentioned. And I was appointed to be a non-political chairman of this committee. And the committee has representation from all political parties in the Swedish Parliament. The three largest parties in the Swedish Parliament has 2 seats in the committee, and those parties are the Social Democrats, the Conservative Party, and the Sweden Democrats. And the remaining parties in Parliament all have 1 seat each. And we're currently putting together a secretariat to work alongside the committee on the investigation. And we have a very large work ahead of us, which shall be completed by June 2025, so it's 2 years from now. Next slide, please. And what is the committee supposed to do? Well, we shall analyze advantages and disadvantages of the transfer of governance responsibility concerning the healthcare system in Sweden. The committee shall also make proposals to ensure a more efficient healthcare system based on patient needs and also taking into account the needs of staff. And in addition, the committee shall also propose an implementation plan which shall include a timetable for how the state can take over governance responsibilities for health and medical care in Sweden. So as you see, this is a very ambitious work and we're just starting it. So I'm looking forward to getting back to you all when we have some results to share and some questions to discuss. And this should not be too far away in the future. Thank you very much for your attention.
Jean-Luc, thank you so much. Very interesting to see, how the policy process is structured in Sweden, and also what your mission is actually to do. And I think it's both, on one hand, it's very technical. It's about, what happened when we move some of the governance tasks up to the national level. But at the same time, it seems to be extremely practical, because you are also meant to think about the implementation process and even suggest a sort of timetable. So it's not just an activity of conceptual thinking and weighing. And also I can figure that will be quite interesting, all the debates with the different parties. I mean, you are non-party chairman of this committee, but as I understand, there are plenty of party members and also probably plenty of people from the municipalities and from the, so there can be some controversies probably in the discussion. And I think later on, we will hear from Ingrid, a little bit on the policy style of the policy culture in Sweden. But now, before we go to this, I'm more than happy to ask our colleague Carsten to take the floor. Carsten is from Denmark and he will fill us in on the Danish reforms, because they had a couple of reforms with similar intentions a couple of years ago. Carsten, please switch on your video.
Yes, I'm here, and thanks for the invitation, and great to see that so many have showed up. All right, so this is a short presentation of some of the structural reforms that have been going on in Denmark, but just briefly reflecting on Anders's and Jean-Luc's presentation. I think it's striking how many similarities there are, in spite of the fact that Sweden has not yet gone through a sort of a major Big Bang reform. But otherwise, there's been in both countries a centralization of governance over time. There are issues of integration of care. There are issues of attracting and maintaining staff, sufficient staff, healthcare professionals in the workforce, and so on. So we're facing a number of similar issues. Even though we have gone through structural reform as an attempt to resolve some of these issues a few years back. So starting back in 1970, we did a municipal reform. So amalgamating the previous counties into 14 counties and 275 municipalities. Over time, that appeared to be a structure that was insufficient for delivering the broad range of welfare services required. So that led to the initiation of a new reform in 2007, where the regional level was further reduced down to 5 regions, and with 98 municipalities taking care of welfare services. So the regions mainly responsible for specialized health services, so hospitals and GPs, etc., and the municipalities responsible for a very broad range of welfare services. And one thing that was introduced at the time also was mandatory health agreements between the regions and municipalities in order to try to solve some of these issues of integration across the care levels. Then what has happened since 2007 basically is an ongoing change, centralization of the hospital structure, or rationalization of the hospital structure. So reducing the number and the closing smaller hospitals and creating hospital networks. And part of that has been a reorganization of emergency care. So closing a lot of the emergency care entries and really trying to centralize those into better equipped and better staffed units. Then there's been an upscaling of the capacity in the municipalities, so introduction of new organizational forms with acute beds, better rehabilitation, home care services, etc. There's also been the introduction of a budget law with sanctions for exceeding budget limits at the regional and municipal level. So that's an example of a centralization of the economic governance of the system. Also, planning of hospital specialties is centralized, and we've introduced a medicines council to make more centralized decisions about introductions of medicine. So next slide, please. Now, if we look through the literature, we'll find that there are many theoretical arguments, both for and against decentralization. So it's not easy to answer the question that Matthias set out initially. You can really find both in terms of efficiency and in terms of democracy, arguments on both sides. And that means in the end, it comes down to a value-based assessment of efficiency, equity, democracy, etc. But it also means that you have to consider how things work in practice, because one thing is setting up the structure, but what really matters, I think, in the end is how you bind the different levels and the different elements together. So as Matthias said, how do you create a type of accountability, and how do you create a steering structure where you have sort of checks and balances between the different levels? So if you could push the button, please. Yeah, so as I said, really the key issue is the configuration of autonomy and the mechanisms for coordination through multi-level governance. And what is that? Well, on the next slide, my final slides, we can see that. So some of the instruments that are used in the Danish setting and more generally would be to apply hard legislation. So as I mentioned before, the budget law with automatic sanctions is an example, the general health legislation, etc. But it's of course also economic steering. So how to set up the steering system between the state and the regions and municipalities. And a key issue here in the Nordic setting, both in Denmark and Sweden, is the development of an agreement structure whereby the state and the regions, municipalities negotiate economic frameworks and try to come up with policy directions alongside these economic frameworks. So that's a key example of a collaborative governance perspective in the Nordic region. Soft regulation and information is of course also important. So setting up norms, standards, guidelines. Digital infrastructure strategies is also a key issue for binding together the different parts of the system, and the performance monitoring and quality frameworks that was also mentioned before. And finally, of course, it comes down to also what kind of influence you have on the organization of the regional and municipal healthcare systems, and how you sort of reach agreements on setting up the organization. So that could be guidelines for infrastructure investments, planning the location of specialized functions, establishing, in the Danish case, health clusters around hospitals, where GPs, municipalities, and hospitals speak together. So overall, what has happened in Denmark since 2007 is a gradual centralization and also an increased use of all of these 4 types of mechanisms to improve the governance. There's been a tendency to drift from soft to harder legislation. And in the background, you could say the regions kind of operate in the shadow or running the risk all the time of state intervention. So that's also a key sort of steering lever from the national level. And with that, my presentation is concluded.
Thank you so much, Carsten. It was so interesting to hear, especially, you know, following the presentations from Anders and Jean-Luc, because as you said, there are a lot of parallels. And in a way you said, oh, decentralization, recentralization, there are lots of arguments, pros and cons, maybe it's a value-based decision. But then at the same time, you know, we have the Swedish case, which are looking for a bit more centralization. We will hear in a minute about the Finnish case, a little bit more about centralization. And even though sometimes it's difficult to say whether the glass is half full or half empty, I think there are plenty of countries which are playing with centralizing at least some functions and tasks. So I think there's something below it, and probably it has to do with efficiency, it has to do with technologies, it has to do with complexities, all this kind of stuff.
So my point was not that structure doesn't matter. It surely matters, but we need to pay close attention also to the governance mechanisms that are used within the structure. So that was the point.
Thank you so much, Carsten. And now it's my great pleasure to invite Lina Kaiser to fill us in on the Finnish case. And Finland just went through a lengthy but very thorough process of recentralization to some extent, actually. Lina Kaiser, please.
Thank you, and good afternoon, everyone. It's, as always, a pleasure to be here, and especially now that I can finally tell something about the Finnish reform, which really has taken a long time to be implemented. If I can have the next slide, please. So what we've done actually in Finland is that we have centralized our health and social service system from a little bit over 300 municipalities to 21 counties that are governed by democratically elected councils. And what we've also done is that we've centralized the funding of the system to the state. If I can have the next slide, please. Here you can see the sort of the division of tasks between the different levels. And in addition to creating this kind of a county structure, which is a new administrative level in the Finnish healthcare and social service system, we have quite dramatically centralized the governance and both the economic, in the economic terms, but also in the terms of normative governance to the state level. So basically, currently the state funds the counties, or the counties get all their income basically from the state, but the state also has quite a lot of power in terms of directing and guiding the operations of the counties. So we've kind of done both. We have centralized to a county level, but more importantly, we have also centralized to the state level a lot of the governance power of the system. And in the municipalities which still exist, they are left with a shared responsibility for promoting health and well-being of the population, and of course many other activities that are important for the well-being and health of the residents. If I can have the next slide, please. This has been a long journey from a very much municipal-based health and social service system to a county level and state-led structure. And what is interesting, I think, and also maybe interesting for the Swedish case, is that the challenges have been very similar to the Swedish and to the Danish case. And these have been acknowledged already in the late 1990s. So if we look at the government program, for instance, from the late 1990s, it has basically the same. It says basically the same things we see in the current government's program. And also the aims of the reform: to increase efficiency, to improve access, to decrease demographic and to geographical disparities and inequities, and to sort of answer to the demographic challenges we are facing in Finland due to the population aging. These all aims have been there already in the early 2000s. And how I try to, or like to interpret the Finnish reform is that it has been sort of a path we have chosen to walk through. And along that path, the successive governments, they have proposed different kinds of centralization reforms, which have all shaped the system towards the one we have now implemented. And what has been also critical and also a great barrier to implement the reform has been the large political and ideological interests that have been involved in reforming the system. The municipal autonomy has been very strong in Finland, and that has been one of the major barriers in the Finnish case, because if you centralize, then that means that somebody will lose its power and influence. And to sort of reconcile all the different interests in the Finnish healthcare and social service system has proven to be quite difficult. And partly because of that, it has taken almost 2 decades to centralize the system. There will be next steps. So I don't think that this will be the final version of the Finnish health and social service system. The question is what kind of steps. And also, I think it's important to keep in mind that the system has actually also evolved and has been influenced by different kinds of other reforms that have not been structural, but more due to the softer forms of governance. And at the municipal level, there has been also centralization already before this reform. I'm very happy to take questions after or when we move to the discussion.
Kaisa, thank you so much for this excellent presentation, and quite interesting to see similar developments like in Finland, that some small steps and re-centralization took place even before the reform, and also very interesting to see that you already say now after reform is before the reform, because the next step to come and there will be tweaking and adjustments and maybe surprising further developments. So that's really very interesting, and I think that from Denmark and from Sweden, I think that many countries can actually learn quite a lot, and can be informed on the ways to re-centralize a couple of tasks in their systems. Before we go to the panel discussion, it's my great pleasure to ask Ingrid Schmidt to take the floor. Ingrid is representing Sweden in our steering committee, and we've working with her quite a lot. And she has a lot of insights in the policy making, and maybe Ingrid can give us a little bit of an insight, on the political culture in Sweden, because it's interesting to see that we all understand we have a problem. So what do we do? First of all, we set up a committee to get some sort of consensus. Ingrid, please.
Well, thank you, Matthias. I'm sure that Denmark and Sweden share some similarities when it comes to how we want to work in a consensus way when we develop health policies. And for example, the committee that we heard about before, the committee tradition in Sweden is often to include all kinds of interest groups, professional groups, patient organizations. So it's a kind of a process where you together work to form policy. At least that's within healthcare policy, that tradition. And also you might also know that we do have, which is very advantageous in this situation, of course, we have a great trust. There are a lot of research showing that Sweden are benefited from a great trust between different governmental institutions, between different regions and different institutions in society, which is very advantageges, of course, for this kind of a process. And these issues usually get some attention from other countries. So that's that. And I think at this point in time, I think it's also we live in the post-COVID world now, and after COVID, I think that insight of that we have to do things much more together from the different level has increased tremendously, and that has to do with how we are prepared also for future challenges in the healthcare system. It's likely, if you listen to experts, that we will have new pandemics and also meet other crises, for example, related to climate change. And in that reality, the importance of doing things together and develop a sense of who is doing what and when, despite different interests of regions and political parties, is essential, I think. And also to learn from other countries. European Observatory has this long tradition now of helping countries to learn from each other in different areas. So I hope that the committee will take advantage of that, the possibility to arrange seminars regarding important issues relating to the issues that the government hope to solve. And specifically, I would think that it would be interesting to focus on whether the processes in, for example, Finland and Denmark how that has affected prioritizing in healthcare. I think that is what is underlying a lot of problematic issues with access, and that the politicians often lift up, at least in Sweden, long waiting times to planned care has to do with reluctance in the regions to work with prioritizing, even though we have it very clearly stated in our legislation. And I think what the regions and many others professional groups are hoping for, I think, is to have more guidance around these issues. And I think it would be interesting to hear more from Denmark, Norway, Finland, and maybe other countries too that have. I mean, we all share a lot of challenges, similar challenges, how these mechanisms of prioritizing, for example, how do we increase, we know we can prevent 70% of the disease burden. How does that look? Has the government or from the national level had an increased opportunity to guide in a direction that would prioritize prevention and health promotion, for example? We have an ongoing process right now in Sweden that where we try to strengthen primary care. We haven't seen so many results yet, but there is a lot of good work being done, but still there are huge challenges in making healthcare, especially physicians, choose to work in primary care. As we heard Anders mention too, it's a long way back challenge. So that was that. I think.
Ingrid,
some reflections.
Thank you so much. When you started and you were talking about trust and then you were zooming in on the challenges to come, I was thinking about trust and transformation, which is actually the theme of the WHO Ministerial Conference this December. And I think rightly so, because for the big challenges and changes to come, we need a lot of trust in the agencies, in the institutions, in the politicians. And you were also talking quite a lot about leadership. And if I understand your reasoning correctly, then this commission actually has also a role to establish leadership, you know, at all levels, that we have guidance, which direction to go, and is an opportunity not only to talk between the different levels, but also with civil society and society in general. It's very interesting. Thank you so much, Ingrid. And now I would like to ask all speakers to switch on their cameras and videos. And Erika, I just had one eye on the chat, but it seemed to be quite lively, wasn't it?
Yeah, quite a lively chat. Lots of really interesting questions coming in, and also people talking about the experiences in their countries. And so just a couple of questions to kick things off. What data and indicators do you need when you're doing the analysis as background for these kinds of reforms? What do you need to know to inform these sort of large scale centralizing, decentralizing reforms in a country? And adding on from that, it's sort of, how do you factor in demographic change? So how do you cope with depopulating areas? How do you cope with population aging and the way that that is changing in different parts of the country? How do you factor that in? And maybe this is one for sort of more for Denmark and Finland, because they're further down the road of these changes. But what were the capacity building needs in the at the regional level to make sure that this reform could actually go ahead successfully? There are more questions coming in, so I'll do another round.
That's a lot of stuff, you know, for a first round of questions. Maybe Anders, you start responding to it.
Yeah, I'm struggling how to respond to it, but I will make a try at least. My guess is that in order to be able to talk about structural reform, you have to point towards a certain need, and that need should then to be connected to some kind of experience problems related to access, related to geographical inequities, things that people really care about. And I think that we have those problems in Swedish healthcare, and that is sort of a first step that you need to have in order to be able to talk about structural reform. Having done that, I also think that storytelling becomes perhaps more important, because we have a lot of challenges related to transformation of the healthcare sector, the lack of transformation of the primary care sector. We have sort of a digitalization that also requires transformation. We have a need to concentrate services further, at least in Swedish healthcare, I think. And that is more about future development that we would like to see, but we don't have data upon it. And then I guess storytelling becomes more important, how things could be in 20 years if we manage things well. And also as part of that, if we don't manage this well, what we will end up with.
I think it was
Thank you.
Extremely fantastic response for first try, Anders. And the one thing which we should all take is you need some basic performance measurement, and this sort of performance measurement, which also really makes sense to people, to patients, to citizens. I think that's very key. And then the narrative, you know, it's not just about fixing things or exchanging a pipe or something like this. People need to understand which direction we are going and why things are changing and why it is for the better, actually. I think both elements are very, very important. Jean-Luc, you heard what Anders was saying, you know, and you are, so to say, in this chain, the next link. Give us a little bit of your response.
Yeah, I think Anders is absolutely right. I mean, it's also interesting when the Swedish government wrote down the directives for for the committee, they're very much pointed towards patient needs and the need for the work to be done to be driven by the current problems. Just as Carsten pointed out, you could find a lot of theoretical arguments for different systems, but we should be driven by the problems, the current problems of the Swedish healthcare system when we're trying to reform. So that will be a focus on the work of the committee. What matters to patients, basically.
Jean-Luc, if I may ask you back, I mean, will be operating in a very political environment. And of course, in a political environment, there are values and sometimes also ideologies. But now you tell us it's all problem-driven, the discussion.
No, but I mean, if you take the starting point is what the patient perceives as problem, because healthcare is for the patients, a lot of the people. I mean, and the politicians are there to serve them. So, but I think our committee can help them to, you know, map out like a political map of different ways forward. And there you can find then you have room for, you know, prioritizing an ideology and different views. But the map should be based on sort of knowledge and what we know about systems and indicators and so on. So I see there's room for both, a need for both.
Okay, thank you so much, Jean-Luc. Now, Carsten, you had some time to think about a great answer, please.
Well, if we look back to the Danish reform, there was a committee also working on these issues, and it really went through the entire welfare state and looking at it sector by sector. And in terms of the healthcare sector, it was very much sort of driven by data about quality and inequality across the geographical areas. So it was the inacceptability of different access and different quality in treatment across the regions. And then, so that was the main issue. And the other main issue was about future challenges. So building a narrative about what kinds of issues and challenges were coming up in the horizon with the aging population, growing number of chronic care patients, and so on. And then the feeling that there was a need to centralize the hospital structure in order to deal with that, and at the same time scale up the primary care sector. So enabling the municipalities to deal with a number of these issues, so giving them a larger role, and all of that necessitated the creation of larger units was kind of the narrative at the time. If I may comment on a slightly different point, which is to Ingrid's observation that consensus seeking is a feature of policymaking in both countries. That of course is true and has historically been true, but the Danish reform is an example of where that sort of tradition was kind of broken in the sense. And that leaves the question, what were the conditions that enabled that at the time? Why has this happened in Denmark and not in Sweden? And I guess part of the answer is that the particular parliamentary circumstances at the time, and that you needed to have strong policy entrepreneurs, both within government and outside government, that kind of form coalitions to push this through. And that really made it possible, also because there was a weak mobilization among the opposition at the time. And that enabled this big bang reform in Denmark at the time. And it hasn't in Sweden so far. But it's interesting to see that we've ended up in somewhat similar situations anyway. So gradual sort of rolling centralization of some issues.
Carsten, thanks a lot for this insight on the politics of change, actually. And Lina Kaiser, maybe you could also have a couple of reflections on what Carsten just said, because I saw you nodding all through, and it seemed like you could really relate to it. Please, Lina Kaiser.
Yeah, in a way, I can relate to that, even though in Finland, the reform has not been that big bang than maybe in Denmark at the time.
Wow.
Well, it's been a big bang, but we saw it coming in a way. But in terms of like data and how that and what kind of indicators we need to maybe support the reform or to evaluate that, I agree that what Carsten said, and but in Finland, I'm not sure if that was the reform actually was that data driven, even though the argumentation has been a lot based on different indicators. So I don't know if the actual solution we have now created and the actual needs we have are entirely matching, but in some ways they probably are. I think that in all the Nordic countries are a good example of how we need to balance, and what Carsten also said in his presentation, we need to balance between maybe the values of autonomy and self-governance and like having decision-making power close to the people, which all should or would speak for decentralization, and then geographical equity and equality between the all regions of the country. And I think in Finland we have emphasized a lot the latter one, that we should be able to provide equal care across the country, which in the case of Finland is a lot. It's probably similar to Sweden because we are geographically large countries, but then it's different when we compare to Denmark, because I would say that in Finland and Sweden, the challenges of taking into account the depopulation of rural areas, the aging population staying in rural areas, and the working people moving to the city centers, and all that geographical things, I think it's even more challenging in Sweden and Finland than maybe in Denmark. I'm not sure.
Liina-Kaisa, thank you so much. Ingrid?
No, it was just to respond a little bit to Carsten's comments. I think maybe the time now has come for doing some more larger changes in structure, and up to this point, I mean, this has been tried several times before during the last decades, but up to this point now, a number of processes have started that are going in the direction of more national planning and cooperation across regions. And looking at our past now with the COVID, I think that awareness of that we need to plan more together and have more the national level involved in how the healthcare system works. It's perhaps now in for us.
Ingrid, thank you so much. Erika, I think unfortunately we don't have time for another round. We need to wrap up, and I also have to make 2 announcements before we close the session. Anders, can I ask you to give us 1 or 2 messages, that you feel are coming from this webinar today?
I'll provide one message at least that I've been thinking about, and I think it's important to mention that I mean, from an outside perspective, you may think that the Nordic countries, they are similar when it comes to healthcare, and in many I mean cases there are similarities, but if you look more closely, you will also notice that there is a lot of difference that really makes a difference when it comes to centralization, decentralization trends. For example, the degree of decentralization have been different historically. I would say that Finland and Sweden have been the most decentralized system, local government being strongly protected in the constitution. We may be behind in general, I don't know, but we are also behind perhaps if you compare with the forms in Denmark and Norway, but there are historical reasons behind that. Besides that, we also have, I would say that the importance of consensus varies, certainly between Denmark and Sweden, I would say. The reliance on hard versus soft control also varies. And as Liina-Kaisa mentioned, also the geographical conditions, with Denmark being a totally different story, I would say, compared to Norway, Sweden, and Finland. However, having said that, I think that one common lesson is that structural reform takes time. But suddenly things happened. That was the case in Denmark, and also the case in Finland. And we will see about Sweden. I think it will be very interesting to follow, both from inside Sweden, but also from an outside perspective. So hope to get back in this form, Matthias.
Anders, thank you so much for this great summary, and I'm sure we will talk about Sweden very soon again and about decentralization and recentralization. I've now two small announcements to make. Next week, we actually have two webinars. One is making the most of our data, approaches to data linkage for evidence-informed health policy, and it's a very special thing. It's based on our hits, but it's not looking in one country, it's looking across countries, you know, so what are the data systems in the countries? And then on the 21st of September, also next week, we have a very special event because we have our 25th anniversary, we have our celebration, and we have a hybrid event for this health systems of the next 25 years. How do we harness innovation to improve performance? And our dear director, Joseph Figueras, will give a wonderful speech. And we have Hans Kluge, the regional director, here with us, and a couple of other leadership personalities talking to us, discussing with us, whether you are here on site or online. So look up our website, the events page, stay tuned, look up the Swedish hit, and hope to see you again next week. Bye, thank you.